From the perspective of doing the study, things that you need to be aware of and careful is these different steps. The data collection form, and that includes the data collection manual, the operation manual, the database, and the database manual that relates to the data collection form. Pretesting, this is what Dr. Ramirez was referring quickly as pilot studies. Ideally, that would be something that should happen every time they're going to be doing something. The data entry and the data quality. So in the data collection form, I'm listing here usually, regardless of how complex or simple your study is, you usually are going to have either a paper data collection form, an electronic data collection form, an Excel, or any type of other databases if you don't have a tool before that. So sometimes people are entering things directly into Excel, which I find a little bit tricky and risky, but that's what we tend to do sometimes, particularly if you're running out of time. So, and these variables or these items that you will include in a data collection form will change depending on the study. Of course, if you're doing a case report, you're not going to have this. But if you're doing even a retrospective study with not a lot of patients, where you're looking at a disease in particular, or your predictor or your interest variable, you will have a predictor, an outcome variable, the inclusion and exclusion criteria, and the confounding variables that we are going to discuss a little bit, and probably in the statistical part there might be a little more on those. So I put there, and I cannot read it from my computer, and I don't remember from the top of my head. But all these are entries that include or may include judgment. So anything that you're going to be collecting, whatever, inclusion, exclusion criteria, a predictor variable, an outcome variable, a confounding variable, anything that you put in the paper, in the website, in the Excel, that is not objective and simple and one way, you would need, ideally, to write the instructions on how it should be collected, okay? Unless you are the only one doing the data collection, where then you don't have a conflict with other people looking or doing it on a different way. But even if there are two of you, a friend and you, collecting data, I would suggest that for anything that you will be collecting, you clearly decide how it's going to be done. The how it's going to be done not only includes the definition of the criteria, but also from which part of the medical record you collect it. You use, if there is more than one, which one do you use? The best, the worst, the first, the last? Because we collect things and interpret things in a very different way. And that, and if you're not clear and everybody's doing it in the same way, the results may not be exactly what you are trying to find. So this would be an example of things that you need to define. This is the way that we define community-acquired pneumonia in our pneumonia studies. So basically, you need a new or a progressive infiltrate on chest X-ray or CT scan. And then you need new or worsening cough, changes in the white blood cell, leukocytosis, leukopenia, or left shift, and changes in the temperature, okay? Fever or hypothermia. So if I just put this in my protocol and then in the data collection form, and I send all of you and say, okay, go to U of L, now Cerner, and you are in the study, so I want you to collect, I get you the list from billing or whatever of all the patients who were admitted with pneumonia in the last year. I want you to collect these variables. So for everybody in the list that you get, you put if the patient had a new or a progressive infiltrate on the image, if they were having fever or not, if they were having leukocytosis or not. So what is the potential problem with that? That we already found, of course. What is the chest X-ray that I might be using may not be the one that you're using. You might be using a chest X-ray that was done 2 days after admission when I want the chest X-ray on admission. Or the patient might have a chest X-ray before admission, a chest X-ray on admission, and a chest X-ray the next day. Or the patient may have a chest X-ray on admission, but then has a CT scan the next day, and the chest X-ray is positive and the CT scan is negative. So which one do you select? You say, no, this patient has pneumonia because it has a positive chest X-ray, or you say, no, this patient has no pneumonia because the CT scan is negative, despite the chest X-ray being positive. So those are the definitions that have to be clear up front. That's when the pilot testing type of study comes handy. Because otherwise, you're calling somebody pneumonia who, from a standpoint of the protocol and the investigator, may not have it. The same thing with fever. Okay, how many patients presented with fever when they were admitted into the hospital with pneumonia? Well, what is fever for you? 100, 100.4, 101, 99? No, because with 99.5, I'm already shaking, and for me, that's fever. Well, it doesn't matter. What's fever for the protocol? Even if you have it in the protocol, if you don't have it in the data collection form itself, or at least in a manual, the person who's going to go and collect the data may not have read the protocol, or may not have the protocol with them. So these critical things, the ideal situation is that you put them somewhere when whoever is collecting data has, easy access. White blood cell count. Do you consider leukocytosis more than 10.5, more than 11, based on the local laboratory range? So this is probably, I just put there one of the definitions that we use. But defining your variables, whichever variable you're going to be collecting, defining those variables is critical. Inclusion and exclusion criteria. Basically, these are the things, the variables, the items that are going to define the population that is going to end up in your study. Okay? And everybody has heard about inclusion and exclusion criteria. So the question many times is, how do you decide your inclusion and exclusion criteria? If you put a lot of inclusion criteria, okay, the patient has to have the positive X-ray, plus the leukocytosis, plus the fever, plus the cough, plus coming from the community, but not from a nursing home, plus having this, you're going to get a very selective and good population. But maybe instead of 50 patients, you end up enrolling 3, because not everybody meets all those inclusion criteria. The same thing goes for the exclusion criteria. If you have a lot of exclusion criteria, well, yes, you are enrolling in the study or keeping in your database the best patients, the ones who don't have the immunosuppressive disease, that have not been in the hospital recently, that that have all the parents alive and the siblings are healthy and have a house that they own and an education and they work and they have a car and they don't have to travel 5. Yes, that's the perfect population. But then how many patients are you going to be able to find? So the balance between an inclusion and exclusion criteria is what's going to define the end of the study after all. How is that you decide what to collect? Well, sometimes it's based on prior studies, based on your pilot study, because whatever you thought you're going to be finding in the medical record, particularly if you're doing a retrospective type of study, that whatever is there, whatever is not there, you don't have it. Well, you may think that, I'm going to be collecting all this microbiology workup, and then you realize that only 1% of the patients have all the microbiological workup done. Again, inclusion criteria, we discussed this. For our study, the inclusion criteria is meeting the definition of CAP. And exclusion criteria basically are those characteristics that may interfere with what you are evaluating and may give you, not false results, but give you a population that is not representing what you're trying to evaluate. Okay? This is not the same as confounders. So if you look at the clinical trials, how many exclusion criteria the clinical trials have? 50. That they have to be, they cannot die within 48 hours. They cannot be immunosuppressed. So HIV with a CD4 below 200, anybody with cancer, with liver disease, with CHF that is end stage, with COPD that is end stage, anybody who received this drug and this drug and this drug and this drug, anybody who jumped from the cliff 2 days ago. Well, why do clinical trials have so many exclusion criteria in particular? Because most of them are evaluating a new drug or evaluating a new procedure. They don't want to have a patient with 1 million other things that could affect what they are evaluating. So they are excluding all those patients. Makes sense from that perspective. But the question, after you have all the inclusion and exclusion criteria decided, and again, you may exclude patients who are immunosuppressed or who are coming from a nursing home or who are not compliant with medication. Who wants to put an HIV patient in a study that you know that the person is not coming to the clinic, not taking the medication? So those patients never go into a clinical trial. The key question with the inclusion and exclusion criteria, this is something that Dr. Ramirez mentioned at the very beginning. When you're doing a study, what you're trying to do is to answer that question for the whole universe. The city, the country, the world, whatever. But what you're using is just a little piece of that universe, your sample. So depending on the inclusion and exclusion criteria that you chose for that study, your sample might well represent the whole population or not. So this relates to the generalizability of the study. Sometimes it's not that you can choose. Sometimes this is what you have. So if you're doing a study at the VA, because that's the population that you have, because you need a lot of data from other clinics and from 15 years ago, well, what best than the CPRS that the VA has? That's the perfect system because you have every single thing that relates to that patient from any clinic, anywhere. Well, but then the study that you have is with the population from the VA. So whatever you find, let's say the patients who receive levofloxacin died less than the patients who receive ceftriaxone and azithromycin for the treatment of pneumonia. In my sample, in the VA patients who are men over 65 years of age, will that be the same for women between 20 and 30 years of age? I don't know. So one of the comments that I usually talk to when you have a rep from a company or things like that, when you're talking about clinical trials, and they come and say, no, because in this clinical trial, you can see that this drug was better than this one, or this drug was better. And we have like 10 years of this clinical trial, and we analyze this data in 1 million different ways. Yes, in the perfect population of the clinical trial, the ones that I call the healthy sick people. In the ones that you see in the clinic that come 1 out of the 3 times that they're supposed to come, don't take the medication that they're supposed to be taking. You don't see them every month like the ones that you see in a clinical trial. Well, if in the clinical trial doesn't work, go figure in the rest. But just because in that population work doesn't necessarily mean that in your population it's going to work. So when you're trying to decide which patients you include in your data set, as much as possible, if you have that choice, you need to think about what you're going to be using for defining this population. The predictor outcome and the predictor variable and the outcome variable, there are different names that you can look in the literature. They can be independent and dependent variable, the variable of interest, or whatever you want to call them. We usually call them predictor and outcome variable, so that's what you're going to see here. And your predictor variable is basically, the way I say this is the groups that you're going to be looking at. So if you're going to be doing a study on community-acquired pneumonia and looking at patients with or without COPD, that's your predictor variable, the COPD. If you're going to be doing a study of HIV-positive patients and looking at response to antiretroviral treatment and comparing male versus females, the gender is your predictor variable. Okay? In the examples that I have here, again, this is all related to community-acquired pneumonia, so empiric therapy could be my predictor variable. So I'm going to see if this regimen is better than this regimen. In this case, for example, beta-lactam plus macrolide or a respiratory quinolone. I'm going to move this. And this is depending on the floor or the ICU admission. The outcome variable, well, the easy one to think about is mortality. Okay, and that's what many of the trials or studies that we're going to be doing are going to be looking at. But there are other outcome variables that you could use. You could use length of stay as an outcome variable. You could use the time that it takes for the patient to get better. There are a lot of studies that look at quality of life as their outcome variable. A process could also be an outcome variable from the perspective of how the study is designed. And then in hospital mortality, all these things have to be defined. The confounding variables are those that basically, the standard definition in my book will say it's a variable that it relates to your predictor and to your outcome variable. So basically, just by having this confounding variable in the equation can give you a result that may not necessarily is the correct one. So if you're trying, there is one typical example also that is looking at coffee, smoking, and lung cancer. So if you're looking at the coffee drinkers versus the non-coffee drinkers, just that association, that relationship, you find that the ones who drink coffee died more. Well, then every time you find a result, you have to think if it makes sense. All right? So why would the coffee drinkers die more than the non-coffee drinkers? Well, because you didn't take into consideration that the coffee drinkers smoke more. So that smoking becomes your confounding variable in this example, whereas smoking relates to coffee drinking, but also relates to dying more if you smoke. So let's say that you find that coffee drinkers die more. When you do the stats and you put that confounder, the smoking, into the equation, well, that association between coffee and dying more is no longer there. So basically, it was the smoking that was giving you that result, not the coffee drinking itself. Correct? So every time you are defining your Excel, your paper data collection form, you have to consider what you're going to be collecting that could be potentially used as a confounder later when you're doing the analysis. If you're going to be looking at mortality, regardless of your predictor, if it's going to be a disease, a treatment, you always want to have information about the severity of disease, because you would think that if the patient comes into the hospital with a more severe presentation, the chances of dying are also higher. And how do you define the variables that you're going to collect? Well, the ideal situation is that you collect as much as you can. I'm going to collect the whole medical record for that patient. So then I have everything in my database. Well, that may not be feasible because you may not have enough time to collect everything. So you need to define, based on prior articles or your own little research, what is that you're going to be collecting. Remember that whatever you don't collect, many times you cannot go back and collect it. So if you don't have it in that data set, you don't have it for analysis. Okay? Oops. And this is a common, well, I don't know if it's a common problem, but this happens many times when you submit a study for review, particularly when it's retrospective, that this is what nobody likes, because a retrospective study is weak and doesn't have, a good power from a scientific perspective. But we all tend to disagree with that. But basically, you get the reviewer's comment and it said, well, I noticed that you didn't put any information on this. And then it's like, oh, crap. Well, the best that can happen to you is that you didn't realize to include it, but you have it in your data set. You can redo some analysis depending on the complexity of it and improve your manuscript, either for resubmission in that journal or for a new one. If you don't have it, you don't have it. So either you go back and collect it, or that will be a limitation that might kill your study for further publication. It's difficult to think, in advance what is that you need, but you have to be very careful and try to consider that as much as possible. So this goes into the pre-testing part, because this is where you're going to get a lot of information before you realize that you are 8 months down onto your study and you're not going to have anything. The main concept is that a problem-free protocol on paper usually has important problems in practice. When you're writing the protocol from the prior articles that have been published, your thoughts, your colleagues' thoughts, the way that you write. You have all these inclusion and exclusion criteria. You have all these variables that you're going to collect, that you're going to be doing this analysis this way and this analysis this way. And then you do the data collection form based on your protocol. You have it all well defined. And when you go and try and start collecting the data, you find out that 75% of the things that you decided that you're going to be collecting are not in the records. Or you thought that the patient were going to remember when is that they got the vaccine for flu, and they don't remember. So the variable that you thought you were going to have is going to be most of the time unknown. You have to address that. So the pilot study or the pre-testing can discover these problems before you start the study, or before you go into the study a lot, that basically there is no point of return. It's not that you have to do a study with 50 patients. You just can do a pilot study with 4 patients. Keep in mind that, you have all the regulatory things that we already addressed even for this. So there are some considerations to account for before going into a pilot study. So you can evaluate the methods of recruiting for the study. Let's say, you plan, one example. We are doing an NIH study on HIV patients with and without COPD, where we get a bronchoscopy and we get fluid for the lung to look at the redox potential and some other markers, thinking that HIV patients have a faster progression of pulmonary diseases. Well, so then all the HIV patients are in our clinic, so that was not really a problem that we considered up front. But the question was where to get COPD patients or COPD with HIV. So we went to HCOC. And we talked to the pulmonary division and we said, okay, can we go to your clinics or look at your schedule and see, which patients have COPD that we can approach? So we were thinking about the ACB building and the HCOC. And in this study, we have reimbursement for the patient for their time and efforts. Okay? It's a nice way to say that we are paying the patient. Well, in ACB, every time we approach somebody, usually they said yes. For the bronchoscopy, for the follow-up, the blood drawn. Every time we approach somebody at HCOC, they said no. This links to the type of population that you see in one clinic versus the other one. HCOC patients tend to be better economically positioned, may not need that money. That is another critical concept in research. You're not supposed to brave patients to be in the study. So that is a balance that you have to keep. But all these things, maybe we were planning on doing the study in HCOC and we would have not had any patients. Or I'm planning on enrolling, I'm going to do this study on MRSA ventilator-associated pneumonia, and out of the blue, I had not been in the hospital for a long time, and suddenly there are no MRSA VIPs. Well, I'm not going to have the patients. So that is something to consider also when you get studies from companies. You need to look at the protocol, see what their inclusion and exclusion criteria are and the procedures, because you need to define if that is a study that you can do. This is critical. As I said before, retrospective studies are based on data that is already there, available for you. That means that what is there for you to use. What is not there, you're not going to get it because the patient is already gone. That's the limitation of a retrospective study versus a prospective study. If you're trying to get why the patient was studied on this anti-blood pressure medication from the chart and the physician who prescribed that drug didn't explain, you cannot go and ask that person the next day, why is that you gave this person this or that? So that's another consideration when you are trying to define this is something that I'm going to be able to collect or not. And then also the pilot study can help you defining how is that you're going to be measuring the predictor outcome variable, if you're going to have the information or not. So again, pilot study will give you a lot of information from the perspective of the feasibility. And pretesting we already discussed. That will help you also with the study protocol and improve it or change something that you thought that was going to be available. And with the study manual, that is something that we tend not to think about, but it becomes critical, as I'm going to show you next. Any questions so far? Okay. So the data entry, there are different ways of doing data collection and data entry. All the companies now moved into electronic data capture, and they don't have paper anymore usually, so you have to beg for them to give you some data collection form that is on paper, or you have to create it on your own. We in the division tend to do a lot of paper first, that then we transfer to the electronic data collection form because it helps, and as I'm going to show you from a quality perspective, but it tends to go faster. Sometimes, the computer collapses, so you have everything in paper, and then if you have to verify some things, you already have the paper there. So we do paper data collection form first, and then the electronic data collection form, or case report form, that's what CRF stands for, mimics the paper. Okay? The way that you transfer information is diverse. You can do it, directly into a software that you have in the computer. You can do it on a website, and usually most of the things that we do today are web-based. We are using RedCap as our data capture system. Are we having something on RedCap today? Okay. So that was the introduction for the RedCap that comes later. So basically, this is, it's not important, the information that is there if you don't see it, but basically this is one of our pages from the study on pneumonia that we've been doing for many, many years, looking at the demographic and the hospitalization, so the age, the gender, the day of admission, ICU, and all that. This is the RedCap screenshot, where we collect the same information, and then you can see that there are a lot of yes, no's, not a lot of free text, and I'm going to address that a little bit later, but that's another important concept. And then you have another section here that is looking at steroids. So at some point, in all the reviews that we've done for our database and data collection form, we were collecting if the patient was receiving steroids on admission or not. Yes, no, period. And then somebody who was looking at COPD and the effect or the impact of COPD on the outcomes of patients with pneumonia said, well, but if the person is COPD and receives steroids versus somebody who's COPD but didn't receive steroids, you might have an impact on the outcome that is not necessarily because of the COPD, but because of the steroids used. So we need to know which steroid and how often. So we said, okay, good. We did a review first. We were able to find that information, so we decided, okay, not only we're going to collect yes, no for steroids use, but we're going to collect the name, you can see it here, and the dose. So what is that you see here? What is this type of data entry type? Free text. This was years ago when we were not accounting for these details. So we put this is an international study, so you have people from Latin America, from Europe. And we've been collecting the COPD name and dose for several years when we decided to look at the data. So this is what we found. So we had names in English, names in Spanish, names that were all capital letters, names that were all lowercase, names that had the first letter as the capital letter and then everything lowercase, doses that had the total dose per day, doses that have half of the dose. All these things, depending on the software that you use for analysis, are different variables. So if I have methylprednisolone, but instead of the capital M, it's a lower M, these are two different names. So it's not going to be accounted as the same medication. This is critical. What you get in the database is what the statisticians are going to be using for analysis. So if what you get in the database is garbage, they could be the best statisticians in the world. They're going to give you results based on the data that you collected, which is garbage. So what result you're going to get? Garbage. Pretesting, pilot studies, data collection, data manual come critical to this point. You can have the best data collection form. You think about which data collection form you're going to be doing. You have all the different variables. You try to avoid free text as much as possible. So the free text that we use is usually for that answer that says other, and that is only to be used for those things that you cannot think in advance that you want to collect. Okay? If I'm going to collect data on pregnant females, and I know that I want to capture the first, the second, of the third trimester, why am I going to put a free text for people to type first, second, and third? I would have first with capital letter, first with lowercase, first with a number, with ST, without ST. It will be 1 million. I just put radio buttons, basically. I'm forcing the person to select one option only, that is first, second, or third. There are no other options for pregnancy. You cannot have a fourth trimester. So when you know the options, but, well, miracles in life happen, so let's leave it there. When you know the answers that you want to capture, those need to be pre-specified. You always leave the other because the other is always a possibility. But if you want to capture comorbidities and you know that you want to have cancer, CHF, COPD, HIV, diabetes, hypertension, whatever, just put those there. Don't leave the blank text. Then you leave the free text for anything else. The other concept that goes along with this is that if you just put check boxes, basically the people checking if it's a yes and leaving blank if it's a no, that makes sense because every time you open a case report form and you see 50 yes, no, yes, no, yes, no, yes, no, you just want to shoot yourself. Because you know that even if it's a no for the majority, you are going to have to mark the no, 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 no. From a statistical analysis standpoint and a data quality standpoint, if you only have checkboxes and the space is blank when you are reviewing the data, what are the possible options? That it was a no, or that the person forgot to check it, and it was actually a yes. How is that you can verify that? No way. Well, you can send it back and hopefully somebody will review it. That's why over all these years, we moved to every single thing that we could put as yes, no, as a yes, no. So if they are excluding among them, if the variables, the answers that you have, exclude themselves, so you can only have one option, you just give that option. You can pick one. If you have more than one possible answer, all your answers should be yes, no. If this is in paper, if this is in a website, the most modern website that you can find, if you're using an Excel, you can format the Excel to have those possible answers there. Do it. Because an empty cell is the worst that you can have in a database from the perspective of knowing if that's really empty or not. And this tags along with the data quality. The data quality, data management is all part of the same process. You do data quality at the beginning, in the middle, and at the end, and then you start again. So data quality can be done at different levels and by different people, and I have a slide at the very end that is going to show you what we develop over time and what we are doing today. So within data quality and data management, as I said before, you define each variable. You don't want to find the mistake of different ways of defining a chest X-ray when you finish the study. And then you have to go back and review all the chest X-ray to make sure that everybody called pneumonia what you wanted everybody to call pneumonia. The study database and the data dictionary is something that, in general, we don't do up front. And we should do it up front. From the perspective of the data collection, again, how you want people to collect data, and from the perspective of the statistical analysis later, how is that the data will be saved? When you're planning the study and you're defining the database and developing the database with your programmer, your computer engineer person, the statistician, you said, okay, I'm going to put males as 1 and females as 0. And that is kind of simple because you have one or the other. If you don't have a data dictionary, 5 years down the road, you may not remember how you decided to code it. Well, I'm going to put the susceptibility report as 0 not done, 1 sensitive, 2 intermediate, and 3 resistant. Oh, and you don't have a data dictionary. So later on, it's like, oh, was 0 not done, or 0 was susceptible, because usually we put 0 for the ones that were 3. Either you go back to the medical record and try to match the data, if you can, and then hopefully get that coding, or you don't know what is there. So the data dictionary and the study database and the data protocol from the perspective of collection, that is something that it takes time, it's painful. Anything that relates to this presentation is painful, including the presentation maybe, but it's something that it's critical to do up front, even while you are planning, because you might need to change some things. Data editing and data and quality steps relate to finding the mistakes, the errors, the things that are out of range but are permitted, the things that are out of range but are not permitted, that make sense, that don't make sense. You know, as you are doing the study, you don't want to finish the study and have your statistician coming back saying, well, you know, this is an international study. We have BUN here, but in other countries they have urea. So we have numbers and units without units sometimes, so we don't know if this number is BUN because some of these things overlap in the range. So the data editing and the quality steps are done at the same time that you're doing the study. And not to mention backing up the data set regularly. That is important because if you lose that data and you don't have it back it up, you are done. Define each variable. I'm going to go quickly through this. Usually we use the paper CRF, and this is the way that I've been working so far, although now I'm a little bit out of it, but usually I use the data collection form to sit down with the person who's going to be doing the database if it's not me, or the statistician if I'm not going to be doing the analysis, and say, okay, this variable in the paper is going to be collected that way, and then we decide we're going to code this way, and we're going to put this type of data this way. Just try to be simple. You have to know either because you do it or because you talk to the statistician or to your database manager or whoever is going to help you with the database. You need to know how that software works from the perspective of how you're going to call these variables. Sometimes this is done by the person doing your database or the statistician, but without communicating to you, so then you don't have a clue of what it is. Not to mention that if that person leaves your office before giving you the coding or the manual, you have a database that you don't know what it means. If you're going to abbreviate things, use it consistently. If you're going to abbreviate antibiotics, don't use ATB on one place and ABX on a different place, okay? Common sense, but that we tend to forget when we are doing this. And then usually use lowercase because there are a lot of softwares that the upper cases are not recognized or don't work very well. Define each variable, as I was saying. This is what I was saying. This is an example of our data collection form. As you can see here, I mean, when I was doing this before, I was using the name of the variable in red and the type of data in green, systematically in all the data collection forms that I was developing and working with our statistician to develop the coding system. So you just find the methodology, and if somebody else does it for you, you need to know what that somebody else is doing for you. We discussed the database and the data dictionary. There are different platforms that you can use. This is an old slide that I have not updated, so you see that we don't have RedCap there. Access is what we were using in the past. All of us use Excel for many different reasons. Excel is a very nice system that lets you do reports, graphics. Excel, from my perspective, is not a database or a system to use if you're going to collect a lot of variables or with a lot of possible answers or a lot of patients. The risk of messing the data up, to me, is too high, okay? So the pilot study, you can have an Excel. When you're starting developing your study, you could have an Excel. If you're planning on having a lot of variables based on your data collection form or a lot of patients, avoid Excel. And RedCap is what I think it works very well nowadays. It lets you export and do other things. As I said, set up the database, the data dictionary before you start collecting any data, the data collection form manual on how it's supposed to be collected and how the data is being stored before you start. Describe the variables, describe the name of the variables, describe the type of variable and how the data is being saved. I cannot repeat this over and over and over enough. This is critical. The data dictionary establishes the basis for editing. Again, anything that you define there is what you're going to be looking later when you're looking at the data and defining if that data is correct or not. What we do for data quality basically is we make sure that variables are not missing. That's where the yes, no type of question comes into place. We are looking at the variables are within the permitted range. Depending on the software that you're using, some of them let you have a query defined that if the data is out of range, that person cannot save it. If you know that there is no way that, I mean, you cannot have somebody who is 137 years of age. So if you're looking at age, there are some software that really lets you put a range. If you're doing adults, you don't want anybody who is younger than 18. So nothing can be saved from the age variable that is younger than 18 or older than, whatever, 115, whatever you decide. And then again, that are logically consistent with other variables. So if you have age in this section and then you have age later, and it's something that is not automatically entered from the date of birth, you want to make sure that those two ages are the same because it's the same patient at the same time. This is just a flow chart or a type of figure to show what we do. And quickly, over time, we develop a process where we put data quality at different steps. So the A will be the person who collects the data from the medical records to the case report form in paper, and then B will be the person who transfers the data from the paper case report form to the electronic case report form. So depending on the number of patients that you are enrolling and the number of people that you have, you may not be able to go back and review every single patient to see if what is in the paper and in the database is what is in the medical record. But if there are some things that for you are critical to make sure that are correct, age, gender, address, if you're doing something with location, you could have a way that the person doing the data entry, and this is what we are doing, goes back to the medical record for those three things to match them up. So you're not going to be monitoring and verifying the whole case report form. So that part of the data quality, it's going to be missed, the source itself, the source document from a medical record perspective. But at least those things that are critical for your study, if you really need to make sure that are correct, again, if you find somebody who is 57 years of age in the database, well, it's an age that is permitted, so you don't know if it's truly correct or not. The only way to truly verify that age from that perspective is to go to the medical record itself. If it's a critical component, you probably need to do it and have the system for that. So this thing of the data collection form in paper and the data collection form in the electronic version is another step where we do the quality. The person collecting the data in the paper is different from the person entering the data in the website. And that transfer of information is one of the first steps from our data quality perspective. something that doesn't make sense in paper cannot be transferred to the electronic data. Okay, so if I have somebody who is 15, that person doing the data entry should not be moving that information to the electronic database. That happens sometimes, so then it's when you have the other systems in place that is more from a reporting standpoint and data analysis standpoint where you are working directly with the database. So that's where the statisticians, or if you have a data quality team looking at the database from a reporting perspective, you can set up queries that says, bring me all the cases that have an age below 18. Well, the person who did the data collection missed it, the person who entered the data missed it, and then I'm capturing that error from the database directly at this time. And then the last part that, to me, is like a backup thing, but it's not the one that you want to have only in place, is the statistician when you're getting the results. When that person is running the numbers and comes and says, I'm having a lot of patients with an empty cell. A lot of variables are missing. That sentence is like, oh my gosh, I want to commit suicide. Because it's like the worst that can happen. It's like, a lot of people don't have this data. And then the question, well, is it something that could be? That's why the yes-no is critical. Because if you have a yes-no, you know that if it's empty, it's because it was not done. And we already discussed the backup data set. So I'm not going to go further so we don't get behind. We can talk about questions if you have later. But anything quickly that we might want to address now?